that the foundation of your hormones is going to be adrenals, hormones, and insulin. So that, and I say this pyramid because if that foundation is right, good luck with anything else. Good luck with anything else. Above that comes thyroid hormone. And at the tippy top are sex hormones, estrogen, progesterone, testosterone, which is like where women have like a lot of their symptom woes and they want to address right away. We can address those symptoms, but also understanding if we don't go down to that foundation and address that, that can be a problem.
Today, I welcome on the show my guest, Dr. Jolene Brighten. Dr. Brighten is a board-certified naturopathic endocrinologist, clinical sexologist, and prominent leader in women's medicine, a fierce patient advocate and completely dedicated to uncovering the root cause of hormonal imbalances. Dr. Brighten empowers women worldwide to take control of their health and their hormones. She's an international speaker, clinical educator, medical advisor with the tech community, and considered a leading authority of women's health. Her most recent book, Beyond the Pill, walks you through the steps needed to figure out your particular hormone imbalance and offers guidance with her signature protocols to get you back to a healthy cycle quickly. All right, I'm welcoming back on Passion, Love, Pursuit, Dr. Jolene Brighten. I had her on my podcast very briefly to talk about hormones, fertility, and overall women's health back when we recorded at the Health Optimization Summit. And we had a really powerful conversation in a short 15 minutes. And I'm so happy you're back here so we could really go into the trenches, get really deep on this topic. And I know you're just going to provide so much goodness today. And I know your audience is just soaking in all the answers that they've been asking you. And there's a wealth of questions they have about women's health because, to be honest, we aren't really taught this in school. Like, what are we taught in school? If I were to go back, I don't think it would cover like what's a normal cycle or what's what to expect of fertility. I don't think they even cover close to any of those topics. So, it's really to get women really clear on how we can maximize our personal health and get, how we could optimize it and address those issues that we think are normal. But we'll debunk that in this episode, I'm sure. So welcome back to the show, Dr. Jolene.
Yeah, thanks so much for having me. And it's so great to see you. I think, most of the time we meet everybody virtually and then we get to meet in person. And this is very special and unique because we met in person, we recorded in person, and now here we are reconnecting virtually. And so I'm really excited to be back chatting with you.
I know, it's so true. That was such an honor to meet you and just feel your energy in the room. And you were just such a bright light. And you, like I said, you just provided so much knowledge. And funny enough, I had people listen to that episode. They're like, it was so good, but I wanted more. I'm like, well, perfect. She's coming back on. But that's true. It's like, what can you share in 15 minutes? It's really just like a little peek into the window. So.
Oh, and it was hard. Let me tell you, like you are a great interviewer because I'm like, there's so much I want to say. And like, I can't, but I'm like, we did a lot. Like we really covered a lot. So everybody, if you haven't listened to that, make sure you go back and listen to that. Cause I think that, it's going to make a lot of like some of these things that we're going to talk about today are really going to connect into that episode as well.
100%. And I'll include that in the show notes, of course. So let's just dive right in. So first thing I want to ask is, as I mentioned, there's so much women don't know of what is normal or what to expect. Like, how could I feel really good in our body, our personal body, and really how do we optimize our health? So what do you think that women should know just off the bat, like about our hormones, and not just sex hormones, of course, but just to have optimal function of their body and their health? What do you think is missing there that people need to know just to start off?
There's a lot. So, and to your point, the number one question I get asked is always prefaced with like, is this normal? Is this normal? It's why my new book is called Is This Normal? Because that's the burning question. And I think once you understand what's normal and you understand how things operate, it is so much easier to navigate this world. And so what I think we're not told about our hormones is that there's actually a myriad of benefits that they bring us. And when we get symptoms, that isn't your body betraying you. We're so often, especially as women, told that hormonal symptoms are just the burden of being a woman, when in fact, symptoms are your body's way of telling you that something's wrong. I think when we talk about weight, I think that's let's just jump into a charged topic right away, right?
Yeah.
Weight, like from the perspective in women's medicine, historically has always been eat less, exercise more. I hate that. I hate it. Is it true that calories in, calories out does provide weight loss? Yes, for some people. However, what is so often left out of the discussion is the hormonal dynamic and that component, and that gaining weight or the inability to lose weight can be a sign of hormone imbalance. And even further than that, eating less and moving more can actually completely sabotage your hormones. So what I want people to know about their hormones is they are in every conversation of health. They should be part of that conversation. They should be evaluated. If you have a problem, that is not because that's just the way it goes. You're hormonal. It's problematic. No, there's something that we can do about it. And your symptoms matter in guiding that.
Yeah, and we'll really address that because it's really getting to the root cause. Like, what are these symptoms trying to tell us? And I think, I love that your book is called what is it called again?
Is this normal?
Is this normal? Yes.
Is it normal?
It's so perfect because I think, like you were saying, like when we get our period, we have PMS and we break out or we have these period pains. Is that really normal? So let's kind of go into that. Like some of the main questions would be like, let's just kick it off. So as far as a woman's cycle, I don't remember being taught about our women's cycle. And to be honest, I don't even know a lot about it. I just know I know I get it regular, every 28 days. I'm pretty in that range. I do know that I could get pretty severe pains when I start it. I always have to take 3 to 4 Advil within the first 2 hours. And then even going further, I know that if I have an orgasm within a day of my period, I will go into extreme pain. And I mean, like I've been to the emergency room because of it. So these things like, is PMS normal? And what should women know about their cycle? Because is this actually a great guide to see where our hormones are and how these influence certain symptoms we're having?
If you are in your cyclical years, your menstrual cycle is the guide. It is the thing to watch, right? So we're gauging temperature, right? To see if we're sick or not. We are gauging a blood pressure, especially as we are in advanced age, we are gauging blood pressure of okay, how's our cardiovascular health? It is only in recent years are doctors now talking about how your menstrual cycle is worth gauging. Now, the problem is that we understand that this is a vital sign. And I'm not talking about just your period. That's the obvious one. But your entire menstrual cycle is a vital sign. It tells us so much about your health. And we know this, and we're talking about this. And yet doctors are so quick to put women on the pill at the first sign of trouble, right? And to be told that your body has to be controlled. Now, I just want everybody to know, pill, great contraceptive if you want to prevent pregnancy. Does it have side effects? Everything that is a medical intervention has side effects. So you've got to choose what's right for you. But to understand that message of saying this is your vital sign, it's important, we want to know about it, and if there are any issues, we're just going to give you the pill and suppress it, and you're done, that's it. I think that's really problematic. And the framing that your body, what I hear from patients a lot is that they feel broken, their body was broken and they had to have a pharmaceutical to fix it. There is a time and a place for using the pharmaceuticals, but I think understanding your menstrual cycle and why these things come up can be so powerful. And to know that, no, it's not normal that you cannot handle being around a human without losing your mind the week before your period. It's not normal to notice that your breasts are doubling in size and they're incredibly painful and you can't even work out the week before your period. You shouldn't be crying uncontrollably and feel like you're just a puddle on the floor, a few days before your period arrives. These are all signs of PMS. And we've been told PMS is normal. PMS, and so that we parse this out, because people do often just blend them together. PMS is not your period. PMS doesn't happen during your period. It's premenstrual syndrome, premenstrual tension syndrome. If you want to get technical, that's the diagnosis. And that's going to happen before your period. And for a lot of people, once that they see that first drop of blood, the mood symptoms start to shift, like the other symptoms start to lift. And that's because for you to bleed, you need to have a significant hormone change happen. And those hormones that were aggravating you ahead of time, they shift, and now you get your period. And then to your point about painful periods, so that is one that that was me. I am the one that as a teenager, I missed school. I remember being like lying next to the wall. I didn't have an extension cord and heating pads didn't reach that far. So I was like laying on the floor with like a heating pad in
I've done
so much
that.
pain. Yeah, vomiting. It just was horrific. And then I would bleed like 7, 8, 9 days, heavy, heavy, heavy. And it would be, it was just like, I just had to have sacrificial clothes, I had to bring clothes with me to school. I have a lot of trauma around that because, and I think a lot of us do as well, because it's, I think if universally there's one thing we are all taught about our bodies, it is shame. It is to be ashamed of them, that the things that they do that are totally natural functions are shameful. And our periods are one of them. We're taught to be ashamed of that. And yet, there's an entire species called, there's this entire human race because we bleed. It just blows my mind that I ever subscribed to that. But what I just described, none of that's normal. It's not normal. I thought it was. I dealt with it for years. And then my doctor's like, no, just start the pill. And I didn't I wish that somebody had told my teenage self that wasn't normal. And there were also options, because on the pill, I traded some significant depression and yeast infections and things that I didn't want to deal with either. No libido, I just no fun. But with that, in some instances, it could be as extreme as this is a sign of endometriosis and we need to investigate it. And so, no, it's not normal and you should investigate it. Or it could be what I'd say the majority deal with is prostaglandins, and that we've got an issue with these hormone-like chemicals getting crazy with the uterus and causing it to contract. And the uterus needs to contract. It's how we're going to get that endometrial lining out. That's what you're shedding during your period. Oh, but those prostaglandins can just get a little too excited, a little too ambitious, and coming in with things like omega-3 fatty acids. If we've already shifted the diet to include more omega-3s, less omega-6s, we may need to supplement it with a good 1,500, 3,000 milligrams of omega-3 fatty acids ongoing, because that's how your prostaglandins are synthesized. You get too much omega-6, they throw a wild and crazy party in your uterus, and it's a good time for them. It's not a good time for you. And if you get more omega-3s, they're still effective in doing their job, but they're just not as potent in terms of contracting the uterus in that aggressive fashion. And then magnesium. And it's something that, bringing in, is there what doesn't magnesium do? It's so wonderful. But bringing in 150 to 300 milligrams daily, and then maybe 5 days before someone expects their period, they increase that. So it's 300 milligrams twice a day. And sometimes you don't have to go that high, but if they're extreme, that's what I would have done with my younger self. I would have kicked that off for 3 months so that I could get ahead of things, really replenish my nutrients and get those periods under control. But that all can help with contractions and prostaglandins.
Wow. Okay. So there's so much wealth of information in there. So to unpack some of that. So the first thing I would ask is because this is not normal, what type of testing should someone do to see if they have endometriosis or something else going on? Is there certain blood tests you recommend? And actually, luckily for me, I'm getting blood tests next week, and I have not done a full panel in a long time. I recently did a hair analysis test at the Health Optimization Summit, which was so beneficial, which I highly recommend anybody does, because this really tells you where your magnesium is and your hormones and so many things. But when it comes to blood tests or certain tests, what would you recommend to get a lot more clearer on where you are at besides knowing your symptoms?
Yeah, I love that. I'm getting blood work done next week as well. And like, oh, the timing of it.
Yes.
Okay, so firstly, if you have endometriosis, like if we suspect endometriosis, the gold standard testing is invasive. It's a surgical procedure. So we want to be looking at other things as well. So we want to rule out other things with endometriosis. And this is is this normal? So in my book, I actually went through and gave like little mini quizzes, like, could it be endometriosis? Is it PMS or is it PMDD? Could this be polycystic ovarian syndrome? So you can do a little spot check yourself and know what symptoms that you can look for. And what's helpful about that is that's exactly what you need to take to your provider. And that is the exact language that you need to be using with your provider to get them to listen. Because if you just go in and you're like, my periods are painful, they're going to be like, everybody's periods are painful. That is usually what people are met with. Everyone's periods are painful. That's just part of it. Like, no big deal. I really hate when it is a unempathetic female practitioner who's like, well, my periods hurt, so your periods should hurt. And like, what if we could do better? What if we could have better, right? So with that, you want to understand, like, how severe is the pain on a scale of, 1 to 10, the things that I described, lying on the floor, like I threw up sometimes. These things are suggestive of endometriosis. It's not been something that I've never had a laparoscopy. I've never had the surgical procedure to look it up, but I also have been able to move away from all of that and not have those symptoms anymore. So I just want people to understand that it is possible that you can have that extreme pain and not be endometriosis. But, with that, if it is hijacking your life with endometriosis, we can have bowel symptoms as well. You can find that maybe the only symptom is pain with sex. Pain tends to be the most universal symptom, but it doesn't have to be. It actually can show up with infertility, and that usually a reproductive endocrinologist is going to work you up for these things and start doing imaging. So that's the endo piece. In terms of like everybody, like what should we be thinking about in terms of testing our hormones? I think it is a very good idea that everybody gets their thyroid tested annually and have that as a screening exam. Too often, I mean, we know that at least half the people who have thyroid disease don't know they have thyroid disease. And one, it's not being screened regularly. And two, it's also being dismissed regularly. It's like, can we just run this test? It's like, just get if nothing else, just get a TSH, please. But a TSH, a free T4, a free T3. And I think looking at your thyroid antibodies, especially if there's a family history of any kind of thyroid disease, is so important. And for women,
can you repeat
once
those
we get
specific ones?
Yeah, let me
That's okay.
Rattle all that off. TSH, thyroid stimulating hormone, what your brain says to your thyroid. The thyroid gland then is going to produce T4. We want to see the free stuff. That's what you actually use. So free T4. And then we want to test free T3, which is the active form. Your practitioner, so let me just say this, your general run-of-the-mill practitioner will probably give you a TSH if you really work them for it. Sometimes like they're like, you've got to be like losing all your hair and overweight and dry skin and can't get out of bed before they're going to do it. Like, and as you and I know, we can catch so much before it is full-blown disease. We can catch so much and intervene before someone's life gets to that. Because the thing is that yes, there's a medication for when things get so bad, but in that interim, there is life worth living that has been missed. And I speak to this from my personal experience of having gone through thyroid disease, having had autoimmunity, and it not getting, me getting dismissed. And I missed out on time with my infant that I can never get back. Like I can never get that time back. And I think about this all the time with my patients of like, yes, there's a time to watch and wait, but what what can I be advising that they do while we wait for lab testing? While we're waiting to see, like, do these symptoms come back next month? Like, can we make them gone? Like, what can we do? Because they need to get back to living their full life sooner than later. Like, it's just, we only get so much time on this planet. Like, there is no time to like spend not feeling well and not getting supported. So with that, we talked about the thyroid panel, also the TPO and thyroglobulin antibodies, number one cause in developed nations that are iodine sufficient of hypothyroidism, which is too little thyroid hormone, is going to be autoimmune. And even when those antibodies aren't showing it, it's usually still autoimmune because we can't always catch it. We cannot always catch autoimmunity that easily. In some cases, yes, but not always. So that's thyroid, and thyroid's really, really important. And I think I just think it's so worth like beating the drum on over and over so we can keep moving practitioners towards listening and supporting patients and really looking at that, because untreated hypothyroidism can result in cardiovascular consequences that you're not going to come back from in the future. And we don't want that.
Yeah.
Now, when I talk about hormones, and you were at the Health Optimization Summit, so I put up my pyramid. The pyramid also lives in Is This Normal as well, because it's just so important to understand that the foundation of your hormones is going to be adrenals, hormones, and insulin. So that, and I say this pyramid because if that foundation is right, good luck with anything else. Good luck with anything else. Above that comes thyroid hormone. And at the tippy top are sex hormones, estrogen, progesterone, testosterone, which is like where women have like a lot of their symptom woes and they want to address right away. We can address those symptoms, but also understanding if we don't go down to that foundation and address that can be a problem. So if somebody is showing signs that their adrenals are faltering, like they're struggling, so they're waking up with headaches, they're feeling fatigued even though they sleep a lot, yes, that could be thyroid or it could be adrenal. At drbrighten.com, I have a whole article of like, is it thyroid or is it adrenal? Because they can look a lot alike, and that'll help you parse that out. But we will do a thyroid panel, or excuse me, an adrenal panel. And that I typically like to do a dried urine analysis through Dutch. The precision analytical is what they're called. The Dutch test is the test. I should get that correct. But because that's going to look at cortisol and cortisone. There is a misconception that if your cortisol is low, then the problem is we've got to get the adrenals to crank out more. When in fact, so often what I see is people are converting it into cortisone, the inactive form. That is your body's way of keeping you safe. If you crank too much cortisol, it is a pro-aging hormone. We don't want to age that. Yes, stress will age you, and we don't want to age at the cellular level. So the body is going to try to convert that into cortisol, but then we're going to have issues, in terms of like, what I described already, but like not controlling inflammation. Maybe we're getting sick a lot. Like these things can be related to adrenals. So that's one way I like to test, because you're going to test throughout the day. Your cortisol is going to go up high in the morning, low at night, but there's going to be these central points that you want to capture during the day. And doing that via blood work is not fun. It is not fun. And only like if you are like a extreme case of like Addison's, am I sending you in, if I suspect that, which is when you have, that's true adrenal insufficiency, that's adrenal failure happening, that we're going to send you in for a bunch of blood work for your adrenal testing. So we've talked about adrenals. We've talked about thyroid. Insulin, we want to do that fasting. I think I'm like, make this part of your annual screening exam. I do it as part of my annual screening exam because my fasting insulin and my hemoglobin A1C, if those aren't tight, if they're not well regulated, that's going to be a big red flag for me. I've never had issues, like, yay. I would say knock wood, but like really, I'm going to go eat some fiber and like go lift some weights. That's really like how you keep that in check. But with that, it is a very, very important parameter because often we do not see the hemoglobin A1C. That's a marker of what your blood sugar has been for 3 months. We don't see those issues. Development is going to take like 3 months, but we can catch like fasting insulin problems. So your insulin's starting to creep up. we've got issues going on. And I think I would love it to be a lot more accessible to people, but continuous glucose monitoring is a great way to really understand yourself and how you're interacting with food. Because I think that we hear things are health foods, and it's true, but it might not be true for you. So they are healthy and they are great. And like, hey, like that, like oats might be great for the microbiome, and like they do show promise, but you might eat oats, and you might eat oats with like walnuts, and you might be putting like butter, and you might be like doing everything you think is right to keep a glycemic spike. But for you, there's something about that where you're seeing your individual changes go on. Okay, so we've covered like the bottom and the middle of the pyramid. Yep. We've still got the top, but I just said a whole lot of stuff. So I want to break and see if you have a question for me.
Yeah, I mean, so as far as, so we got the 3 key things to look at is your adrenals, your insulin, and your thyroid. And this is the one thing that I really want, and that's why I love biohacking. That's why I love everything you're sharing, functional medicine, is because, you know, when you equipped yourself with this knowledge, anybody that's listening right now, you now can go to a doctor's office and request with knowledge why you're asking this, because like you said, a doctor will not give it. I forgot. Oh, this happened to me with getting my ceramic implant. I thought it was so funny that, you know, you go to a typical, and this is a change of subject, but this is what I mean. Like when you have knowledge, you're able to enter a doctor's office and be like, oh, this is what I want because this is what I informed myself with this knowledge. And they'll fight it, like you said, to get a TSH test. It's like, you know, you have to kind of fight for it. But if you're coming equipped with that knowledge and that you're like certain, this is what I want, this is like, give it to me. You're getting paid regardless. Just order the test.
And family history plays a role. One thing I will say about tests is if your doctor doesn't know how to interpret it, then they might not give you that test, which is fair, right? Because they don't like, they have a responsibility. They have a legal responsibility to interpret that lab test for you and guide treatment. And if it won't change their treatment, they might not order it either. But like these screening exams that we talked about, like in terms of like a thyroid panel, fasting insulin, things like knowing like I have a family history of diabetes, and I would rather know where my fasting insulin is and where my hemoglobin A1C is. Like I would rather, and there are other tests that you can definitely do for your blood sugar, but these are 2 that you can probably get done with your regular practitioner. But when you go in and you have like, these are your family history, these are your symptoms, that can get you a lot further. Something else I will say, that if you have a provider who's dismissing you, I think this is really important for every patient to know. If you've got symptoms, endometriosis doesn't get diagnosed, in some cases for decades, and it's not from lack of trying, it's from providers gaslighting and dismissing women. That's just like the go-to playbook. And so in that instance, if you're faced with a provider who's like that, and not all of them are, okay, there's lots of great providers out there, but if you are faced with that, say to them, what is your differential diagnosis for the symptoms that I'm presenting to you? Differential diagnosis is the thing that sucks. You have to learn to speak their language. You really shouldn't, but it's the reality. What is your differential diagnosis? Have them tell you. You write it down. Make sure they know you're writing it down. What tests have you done to rule all of those things out? Make them tell you. Write them down. And then you can say, I would like you to chart. I would like you to write it in your chart that you are denying my request for X, Y, and Z and Y, and I will be requesting this chart note at the front desk before I leave. And then do that so that you have record of it. Because what that does is it actually makes them stop and think through, like, wait, should I actually really be and should I really be denying this test? Because it's, the thing is that providers are also people, and you have no idea like what their day has been like. It's a very important practice as providers that we leave our baggage at the door. But some days maybe your provider is getting a divorce and they just got hit with that day. And maybe they just left a room where they were delivering like, a notice to a patient who has cancer or someone that lost their baby. And they just got hit with like that emotional overwhelm. And because they're human, their system is shutting down. Like their emotional system has to start shutting down to protect themselves. So when they get into your room, they're like, no, not this again. Like, I'm just gonna like, whatever. And that shouldn't happen in the ideal world, but life is not ideal. And so have compassion with your provider. Yelling at them is only going to get them to shut down harder. And then also, these questions, frame it in a way that makes them pause and think through. Maybe this is not an unrealistic request. Maybe that's not what's going on. Because let's not forget as well, there are, conventional providers out there who are influencers now, who are out there being like, people are so stupid. Everybody's asking for a full thyroid panel and these are stupid people and blah, 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 blah. Like it always cracks me up because I'm like, do you talk to your patients like that? Because there is no way you don't talk about your patients like that if that's how you're talking about people on social media. But those doctors are influencing other doctors. And it's really unfortunate. Whenever I see that, I'm just like, why you gotta be such a hater? I don't get it.
Yeah. Okay. So moving into, so you were going to go into next being the sex hormones. So I know when it comes to hormone testing, there are certain times of your period to get an accurate screening. And a lot of people don't know that. And it's funny, I had someone I know did hormone testing recently, and she mentioned that thing like, oh, I didn't know I was supposed to do it during a specific time. And the craziness is the doctor not saying that, Like
I
what?
have had patients come to me because their doctor wants to put them on progesterone. And I'm like, why do they want to put you on progesterone? Like, tell me about your cycles. Let's go through all of that. Let's talk about your symptoms. Like, maybe you do need progesterone. And then I'm looking in there and it comes back to their labs. And I'm like, well, when did you get these labs tested? Oh, we got them all tested on the same day. What day was that? Oh, I don't know. Okay, what date? Okay, we know now. I gotta like reverse engineer the whole thing, and I'm like, okay, what was the date? Okay, when was your last menstrual period? And we go through and try to figure out when in the cycle. And I'm like, well, of course your progesterone was low. You got it tested on like day 5 of your cycle. Like you just finished your period. You don't make progesterone until after you ovulate. Like to see a sufficient progesterone and actually gauge that, we have to catch it 5 to 7 days after ovulation, which a lot of providers subscribe and as they've been taught to the idea that no one could possibly know when they ovulate. It's just like this mysterious thing, and yet we can. And even if it's like, okay, I'm not tracking my temperature, my cervical mucus, like if that's beyond the, we can get some ovulation prediction kits, and you can just be on the stick and you can see like, okay, it spiked. Okay, you ovulated probably about 24 hours later, maybe 48 hours later. We can do 7 days out from when you saw that spike. We're going to catch that window of progesterone. We can test for progesterone, what people usually say about day 19 to 21 of your cycle. That's not a bad gauge if you just have no idea what's going on and you do have a 28-day cycle, which is only like, that's also not necessarily normal if, or I should say it's not abnormal if you're outside of that, because only about 10-15% of women are having 28-day cycles. But really the ideal is 5 to 7 days after ovulation. We can also test your estradiol, that's E2, that's what you want to be testing in your cyclical years, on that same day to see how are estrogen and progesterone matching up in that. And then in terms of testosterone, the most important thing is getting that done in the morning. That's when it's going to be the highest. So testosterone should happen, we say, usually around 8 a.m. And with that, if you're testing testosterone in women, free testosterone is what we want to see. And testing sex hormone binding globulin, which is a protein, can be super beneficial as well. Because if that ends up low or high, that protein can tell you, well, is it grabbing on there, or, grabbing onto that hormone, or is it not? Like, is that piece of the puzzle, are we answering that?
So good. So good. And so talking about, because I know you speak heavily on this and you did touch on this a little bit, the birth control or any type of contraceptive pill or IUD or whatever it may be. I want people to know, because there's like, I forgot what the percentage is. I read this somewhere. I think 60% of people are prescribed a pill as like a contraceptive pill to help with acne, to help with period pains, and all these nonsense things. And that's not what the pill is used for. We all know that, but people still go ahead and do it. So if somebody is trying to prevent pregnancy at this present time and they're on a contraceptive, what should they know and what would be an alternative? Because we know there's harmful effects of anything we put that is foreign in our body or also like manufactured to change what's natural in our body,
Yeah.
you know? So
Totally. And that's my other book, Beyond the Pill,
yes.
which, it got its name because it's about giving you options beyond the pill to manage symptoms and also helping you know that there is life beyond the pill when you stop. Because so often women are just told that like, it's going to be hell or chaos, hormonal chaos, or, horrible. Unless you want to have a baby, you should just never stop. And in the book, I go through what it is you should know and what your provider should be telling you, because there's a whole lot we're not told when we start the pill. I think one of the top ones that we really need to be thinking about is the impact on gut health, mental health, and our nutrient stores. So, when it comes to nutrition, your average doctor has no education in it. I happen to have a degree in nutrition, which is why it is something that I'm very much like, this has to be the foundation of just about everything because of what I know about it and what I know about health. And with that, we'll see them say things like, oh, the nutrient depletions are not that big of a deal, and it's not like you're going to end up with scurvy. And I'm like, is that the bar? Is that the bar? Is that the bar? We're just like, well, you're not going to get scurvy. Yeah, because you probably put some lemon in your water from time to time. Like that's like the lowest. And yet the pill does affect your antioxidants like vitamin C and vitamin E. Selenium. We also know it can impact your magnesium levels, your B vitamins. And in the biohacking community, what are we talking about? We're talking about mitochondria. We're talking about like your optimal health. And I think that's such a differentiating point is like, there's the like, why do I want to be good enough? Why do I want to be like, well, I don't have scurvy when I could be like, but I feel amazing like every single day. Oh, and my skin looks great, by the way, because you need vitamin C for the cross-linking of collagen in your skin. And like, there's just all of these factors that I think just aren't taken into consideration. And so what does this mean? Does this mean that like if you're on the pill, like you're just going to become nutrient depleted? Probably not. If you're eating a nutrient dense diet, I really get concerned about the standard American diet, people who are being passed the pill or people who live in food deserts. And in those instances, it's a very good idea to be on a quality multivitamin or prenatal. And overall, I think being on those is a good idea if you're taking a drug. And we know, okay, so like if you're on a statin, you're going to be told to take CoQ10. At least you should. God, I hope so. If you're taking metformin, you're going to be told to take B12. If you are taking a drug that has a known nutrient depletion, and you have the potential for that, we supplement and we recommend supplements for that. When I was getting my nutrition degree, we talked all about the oral contraceptive pill, and yet I do not see providers really talking about that with their patients. So that's the nutrient piece. I mentioned the mental health component and gut health, but is there anything that you have in terms of questions around that?
Yeah. So if somebody is not ready to, I mean, there's so many ways I could go because you have such wealth information of so much. So I'm trying to figure out what I really want to tap on in our hour. But if somebody is looking for alternative and they're not ready yet to get pregnant, would you say, I mean, personally, I haven't been on birth control for ever, uh, just precautions per se, but it's because I care about my health and I don't want to manufacture my health. And that's my personal choice. And I do think there's so many things that are altered when you take these certain things or you put a copper IUD in and like all these things, so I'm curious, what would you recommend instead if somebody wants to optimize their health?
Yeah, I mean, friends, the best form of pregnancy prevention in terms of interventions is nothing to do with women and everything to do with men. we can get vasectomies on the table. But for real, vasectomies are, in terms of what they've been shown for side effects, nothing compared to what women put themselves through. And someone's going to jump in your comments. They're going to be like, oh, vasectomies, but men have to have an invasive procedure. Like, oh my God, have you ever had an IUD? Because I've had an IUD, and good Lord, that is like invasive and painful and all the things, because in the US we don't offer pain management as the go-to. No, it should be. But anyhow, the thing that happens so often in this conversation, if I mention vasectomy, is people will fight tooth and nail to once again put the burden of pregnancy prevention on a woman. Always. And why is it okay? Because who does that burden fall on of an unwanted pregnancy? That it's you, it's your body. Like, it's your body that is going to have to be faced with that decision. And it is life altering no matter what your decision is. It's not an easy one. So with that, whatever you choose to use. So even though I'm like, oh, the pill, like, it can have side effects, it can have, cause nutrient issues. Like, I just gave you tips to mitigate that. Like, there are ways to mitigate that, to reduce the side effects, to help take care of your body if you're on it, because I don't know you and I don't know your circumstances, and it might be the best thing for you. And, that goes into like, I can't know the people listening. Like, what is the best contraceptive for you? It's really depends. It's a very individualized discussion. And you're right. So IUDs, the progestin-based IUDs, they have mood symptoms. They have their own side effects that can arise as well. The copper IUD, aside from being painful, if you already have painful to place, if you already have painful, heavy periods, it's out for you. It's going to make those so much worse, and it can make your periods heavier. There are concerns that have not been well investigated in the scientific literature about copper issues and about there being excess copper. We do know from some of the studies that they say if you have copper storage disease, this is not for you. So there's something there to that. Have we explored it in depth enough for me to say like, oh, you need to take zinc and like that will help mitigate that? Because for people who don't know, like zinc and copper, like, you need to have those in balance. But like, there's nothing substantial that we can like really speak to that and say like definitively. I have seen in some women copper issues that I've seen in lots of women no copper issues. So it really just depends. Then we've got barrier methods. Everybody, big fan of barrier methods here. If you are in a non-monogamous relationship or you are changing partners, if you have an STI or they have an STI like, herpes, that's not going to be 100%. I just want people to know. But barriers, we don't actually get this discussion. It's always like, oh my God, don't get pregnant. Be afraid of pregnancy. Like if you're a teenager, it's like, be afraid of STIs and pregnancy. And then there's something that happens as we like get older, and it just is like, just be afraid of pregnancy, like at all costs. Right. And the conversation gets left out of like, who cares if you're on the pill? If you are having unprotected sex, you could contract chlamydia or gonorrhea, which is sometimes silent infection. Sometimes you have no idea you have it, and it can impact your fertility. Like this is a problem. Like you have to be explaining that to women. Also, something that should be part of like your annual testing is STI testing. If you are changing partners, you should definitely get STI testing. If you're non-monogamous, depending on what that looks like for you, regular testing is going to be better. But we are talking about pregnancy prevention, and condoms, they do okay. They have a higher failure rate than the pill, which is why, people like most providers will be like, don't rely on it. But the reason why they have a higher failure rate is usually one of two things. User error, which, I mean, this falls under the same umbrella, but like not putting it on right, or them breaking because you don't have enough lubrication. But the other thing is we're just going to go for a little bit, and then before I ejaculate, then I will put the condom on. And look, I'm not judging you if like, I get it. Like, latex, lambskin, like whatever it is can be an ick factor for people. And I get it. But in that little bit of time, you can get pregnant. So just know, I just laugh at like how many times in my life, like I have personally heard men being like, oh, it'll be okay. Like, I have control. And it's like, no, you don't. That's not actually how your hormones work, buddy. They don't work that way.
Yeah.
And then, the one we haven't talked about is fertility awareness method, which can work really well for some people, but not all people. And with that, it is not rhythm method. I just saw on TikTok the other day, this fertility doctor who was like, if you want to get pregnant, all women usually ovulate around day 14. And I was like, false, bro, false. We do not all ovulate on day 14 because we don't even all have 28-day cycles. And also, why is the base of our pyramid adrenals? Because anything going on stress wise or in the environment can actually impact, I had that whole slide just showing how sleep could impact your ovulation. Like ovulation can shift. So with that in mind, you need to be tracking, and that is going to be tracking your temperature, tracking your symptoms. So one is going to be, cervical position in some people. Not everybody has to do that, but cervical fluid, looking for that egg white consistency. Libido, are you feeling a lot more in the mood? I actually go through like a little checklist in Is This Normal and in Beyond the Pill, because I think it's just so important to know the signs of ovulation and to know what your body's doing at any point. Because if I ask you, are you ovulating? You can tell me, I'm seeing fertile cervical mucus, I've got a temperature spike going on, like here's all the things. And I'm like, that's a really good sign. Regular periods are also a very good sign, just so people know. That's a very good sign you're ovulating as well. So with all of that, in mind, with fertility awareness method, I just think it's important for people to understand that when it's done perfectly, it rivals the pill in terms of its efficacy. So it is up there. It does have a high efficacy rate. However, user error comes in again, just like user error comes in with the pill and not taking it at the right time or skipping pills, but user error can come in. And the biggest user error is that same thing with the condom. There's a fertile window. So you are only able to conceive one day out of the month. You drop an egg, it's got 24 hours to meet that sperm. If that doesn't happen, forget it. It's done. It's over. It's sperm that can live up to 5 days, maybe even 6. And that is only because your womb has given them permission to. And your womb will actually be like, I like you, you're cool, stay for a while. And that's to increase the probability when the egg is released that sperm can meet. And so where people will get this wrong is that, what is one of the things I said, like that will increase, that's a sign that you're going to ovulate? Your libido. So it's really easy in that time to be like, yeah, we're just going to go for a little bit. Oh, he'll pull out in time. 1 in 5 get pregnant in a year with the pull out method. So, and that is something I have heard from patients and people online time and again, is that when fertility awareness method has failed them because they had regular cycles, they could predict ovulation. It had a lot to do with the fact they were not using barrier methods or doing outer course or oral sex or anything else, but like having vaginal intercourse that would expose you to semen. They end up having sex unprotected. They think like, oh, we'll do the pull out method. Oh, we can just go like for a little bit at a time, or oh, I think it'll be okay, even though they know that like you're in that window. And they're like, it's just one time. It's always men who are like, it's just one time. You can't get pregnant if we do it one time. You can't get an STI if we just do it one time. And I'm like, who are your parents? We should talk because they should have told you that's not right.
Wow. Okay. So it's kind of switching on topics a little bit. So one of the big topics, I think you probably get asked this a lot, or actually, let me just ask you, what is the most common thing that people come to you today in regards to, having low estrogen, high testosterone, like, our hormones are out of whack. And, you mentioned some of the things we could look for, some symptoms when our hormones are out of whack, and also the balance of copper and zinc, which is another subject in general. But what should somebody do? Is that a common question that you're asked today? Like, oh, I'm having all these symptoms. Is it common that women today have low estrogen and higher testosterone because I know we I believe we touched on hormone disruptors a little bit in our previous episode. So I'm just wondering, is that a common thing you're seeing today, like a common trend?
Usually, if I see that, I'm looking for polycystic ovarian syndrome. So if we're seeing elevated androgens, low estrogen, and ovulatory cycles, which is the hallmark of, PCOS periods or lack of periods, in that and ovulatory cycles leads to irregular cycles or missed periods altogether. But that's something that we go looking for. You can also see postmenopausally, but I said that really funny. Sorry. Sometimes I just keep moving when I hear myself say something funny, but that time I was like, that just sounded weird. But anyhow, as you enter into menopause, your ovaries are quitting on their production of hormones, but we get a good portion of our testosterone from our adrenal glands. And so we can also see that as the ovaries quit, where you see estrogen declines, and then we see testosterone is still up. That is a situation you will not have had a period for 12 consecutive months. Then you're in menopause. If you are still in your cyclical years and we're seeing this low estrogen, I typically will test on about day 3 to 5 of the cycle. So you're still usually bleeding in that time, unless your estrogen is low, low, low. Then you might only be having a 1 or 2 day period, and that's a sign of low estrogen. And then I will also test in that luteal phase as well when we talked about testing progesterone, just so I can see like what is happening throughout the cycle. Because at the beginning of the cycle, the follicular phase, FSH, follicle stimulating hormone, is getting an egg ready and telling the ovaries, let's make some estrogen. Estrogen has to spike for you to ovulate. So if there's not enough estrogen, and we can't get that spike, we usually have anovulatory cycles, which is another, and that's not the cause for PCOS, but it's another component in all of that. And so we usually won't have regular cycles, but if we still are, it's like, okay, we're getting those estrogen levels up, but are we getting them up high enough? And what's going on with that? There are also tests, just for people to know, where you can test throughout your cycle, where you're testing very frequently doing so. Precision Analytical offers cycle mapping as well, so you can be looking at your hormones throughout your entire cycle and understanding where are they at, are the changes happening, are they following the peaks and troughs that they should be, in terms of how they're operating. But, the most common reason to see elevated androgens, at least in my population, is polycystic ovarian syndrome. And that is something that we just really haven't had enough research on, enough people talking about, and enough providers paying attention to, that I think we are now starting to see it more. But it's not because there's more of it necessarily. It's because there's enough awareness of enough women getting their providers aware to be doing this test, that now they have these tests and now they can see it, which is, comes back to the top of the podcast where we were talking about of going to your provider and advocating for yourself. Because once upon a time, women with PCOS could never get hormone testing. They could never get the time of day from their providers, because about 70% of women with PCOS are struggling with insulin resistance. And when it comes to insulin resistance, it goes, just eat less and exercise more. And to this day, I still hear providers saying, if you just lost weight, you'd cure your PCOS because it's your weight gain that caused your PCOS. Weight gain is a symptom of PCOS. Good luck losing weight when you are inflamed, when you have insulin resistance going on, when your estrogen and progesterone aren't at the levels that they should be. Like, that is something that, can you lose weight? Yes, but we've got to be looking at the root cause and these underlying issues. And just for people with PCOS to know, yes, lift the weights. Yes, eat the high fiber. Like, make sure that you have like a blood sugar friendly diet that's nutrient dense going on. Like, do those things because they are going to help those other issues. We know that lifestyle can have a tremendous impact, but also understand that these things are not your fault, and you may need a provider to come in and intervene. And also, there's nothing to say you can only have one thing. And I think that's important to understand. It's not uncommon to see PCOS and hypothyroidism. It's not uncommon to see, heavy, painful, horrible periods and there be hypothyroidism going on. Oh, and there's this element of PCOS as well, because estrogen is not being challenged by progesterone well enough. And like there's just basically like, I feel like, there's the children's games where like you can, they have like the head, the body, the tail of an animal, and you can like mix things and be like, look at this combination, look at this combination, which is where, partnering with a provider who is experienced and actually understands your health and your hormones can help you so much, because it's very hard to see the forest for the trees when you are just in the thick of it and you're in the forest and it's in fog. Like you're just in fog, like wandering around being like, I know this is here and I understand this. You know your body. Bring that data to a provider who can help you interpret it.
Yeah. And so kind of like closing that off with the whole menopause, as you kind of brought up, and I'm actually asking this for a friend right now, but when it comes to being in menopause and your hormones are out of whack, do you recommend always that if a provider says you need hormone replacement, is that always like the end all be all, or is there a way to get your health back? Like if this person, for example, has weight gain all of a sudden, headaches all the time, low libido, and all these symptoms after menopause, and she's considering hormone replacement, is that always like the end all be all to get things back in balance, or should she be addressing the thyroid, the adrenals, and like all these other things first, I would assume?
Okay, so that's like, in terms of asking for a friend, it's like, well, I don't know you. So there might be like a more nuanced conversation to this. So I am asking, or I'm going to answer generally. Okay, so first thing is, once your ovaries are done, they're never coming back, and you're never going to make estrogen like you once did. It's a done deal. It's unfortunate because estrogen is super, super protective for us. So if you are considering hormone replacement therapy and you're a candidate for it, I'd strongly encourage you to consider it. And I'll tell you why. But even if you are, you do want to be doing all of the nutrition and lifestyle. You need to take care of your adrenal glands, because DHEA is going to be your bestie in helping you produce testosterone and estrogen. So you get a little bit from there as well. And it's an anti-aging hormone. And you still want your cortisol cycling well. That's going to be involved in your immunity. It's going to be involved in your inflammation. Two things that we know are super, super important as we age. But what's really important to understand about aging and what we understand now as women. So I will say, there was once upon a time, I just laughed. One of my stupid 20-something things. Okay, people. Okay, so I was in my 20s and I was like, I would never do that. I would never take hormones. Like, I'm going to be all natural. Then I read some research and then I was like, no. And then I got into practice. Really what turned it around for me is getting into practice and seeing how hormone replacement therapy completely changed women's lives and their labs, seeing cholesterol levels get back into a check. They didn't need the statin anymore. They were using hormone replacement therapy. Seeing their cognitive deficits that were frightening them and their family, that they could be developing dementia, that brain fog, those issues start to resolve. The fact that they were doing what people say can't be done, right? We know it's very difficult to build muscle mass as we age, and especially postmenopausal. That's part of why we start gaining weight, is because our body's like, it's just like Pac-Man's eating up your muscle cells and then just like pooping out fat. Like, it's not like that, you guys, but that's what it feels like. That's definitely what it can feel like, because you are having muscle mass loss. And you can wind up with sarcopenic obesity, which is where you get really skinny. It's the M&M guy, right? Really round body. Adiposity is around those organs, those central organs. That's dangerous. And then skinny arms and legs because you've lost muscle mass. So with all of that, what I will say is that it's really important to consider it. If you were at the Health Optimization Summit, you caught Dr. Amy Killen and I talking about it, we're both like, sign us up. Like, when our time comes, sign us up, because the research just shows us, and I'm like, there's a great book called the XX Brain that I recommend people read. In terms of dementia, women make up we're the largest percentage. We're like 66% of the dementia population. Cardiovascular issues, bone health, cancer risk. What we were told is that HRT would cause us cancer. We actually know now the lack of hormones, that's a cancer risk. So when you go and you actually start looking at them, you realize you don't need a whole lot. And when we're talking about hormone replacement therapy, I would never, ever, ever, ever advise anyone to take oral estrogen. That is when we see the cardiovascular risk of like clots can come up. But you're also going to increase your sex hormone binding globulin. And that's why this happens on the pill, where you lose your libido on the pill, because bye-bye ovaries making testosterone, and hello sex hormone binding globulin grabbing your testosterone. You give someone oral estrogen and you're mimicking that. I also would never ever use contraceptives for hormone replacement therapy. That's not what they're made for. They ain't even good at it. Like, no, forget them. They're out. They like great in your reproductive years, don't have a baby. Like out of your reproductive years, like sayonara, sucker. You don't want to even see them again. Bye, bye, bye. But with that, I would like, if your friend is being recommended it, if anyone's being recommended it, highly consider it. Consider your quality of life. Consider what you want your longevity to look like. Consider what your family risk factors are, and make sure that you talk to your provider about screening. Like, what can I be doing to screen? What should I look out for? Same goes if you're taking a contraceptive or any other medical intervention. I need to know the side effects so I know what I can look out for, so I know when it's time to call your office. That is super, super important. And I will say, when I prescribe hormones, I've got this like big, long, like informed consent sheet that I go over it in person, but nobody can remember all of that. Most of you aren't even going to remember this whole podcast. You got to go listen to it again and catch stuff. And so I put this big list, and people are always like, this sounds really scary. And I'm like, I will not withhold the fact that like things can get scary. There are these scary things. And I want you to not be afraid, but I want you to have enough fear that when something comes up, you don't just ignore it. You let me know as soon as possible. Because if I know sooner than later, I can help you intervene. We can do lab testing. We can stop what we're doing. Like we can do what we need to do to make sure that we keep you safe. And that's a knock on wood. I've never had an issue with women and HRT because I'm using the lowest dose that provides benefits. And that's really what we want to aim for. It doesn't, there was the whole like crew that was like, let's try to get postmenopausal women. We'll give them so many hormones, we get them menstruating again. And I'm like, why? You can't even provide them ovulation. Like, and that is also something where I'm like, they're not ovulating. Like, that's the whole reason that you have a period, is because ovulation failed to result in conception. And so like, why are you trying to mimic that? That it just doesn't make sense. But that's weird. When you saw like cancer and all kinds of issues going up. Don't do that. That's a bad idea. Work with someone who's experienced. And I would also say, like these days, insurance is pretty good at covering stuff, like getting a patch, using topicals. Those are great. I really hesitate. I don't use pellets. I don't advise people to use pellets. I really hesitate with providers who use pellets. We can't be changing the doses as easily. And I just don't like things that once they're in, the patient, like they just can't get it out. Like if they need to, like the implant, I feel the same way about the contraceptive implant. Like we just put these hormones in, and it's not that easy just to like get it out. I mean, it is really minor from doctor mind. It is really minor. It is really easy. But from the patient perspective, I just think that it's a little more of a barrier for them to get help and to continue that care.
Absolutely.
That was a whole lot. God. Is that helpful?
Yeah. It's, I'm thinking as I'm listening to you, I'm like, there's so much knowledge you have. And I know you provide so much knowledge on your socials, on your website. You have tons of blogs, tons of podcasts and videos. And, like, I know you cover everything from fertility to obviously like hormone health to the thyroid. I mean, you go into depths of many seas, if you want to say. And I know it is impossible to touch on all of it. And so, like I said, I'll include the previous show in the show notes, which I know we touched on fertility a little bit in there. But really, if you were to like wrap this with a bow, what do you feel women really need to know about their health to really optimize it? Again, addressing the certain issues. Of course, we have the foundation, the adrenals, your insulin, the middle being the thyroid, and then your sex hormones. If you were to like wrap a bow, like what would you say to women that really they need to know to optimize their health?
Wow, that's a lot. There's a lot I want to say. As you guys know, I'm very loquacious. But what I would say is that you really have the power every day to take steps towards your health, and that the majority of things that you are going to do in your day, they're going to be the things that take you for the long run, or the things that land you in the doctor's office. And you have a lot of power in that. And to know that the things that help you heal, the things that really tend to your hormones, they don't happen in a doctor's office. Like, we do lab tests, we do all of these things, but it's what you do every single day through those lifestyle choices. Like when you make the decision not to work out or to work out, you've made a decision, and you're taking a step towards your health. And I'm saying sometimes not working out is a step towards your health. Sometimes you do need a rest and recover day, but to understand that there is so much power. And I think all of these things get talked about so much. And it becomes, one of those situations where like sometimes my patients are like, yeah, I know this. I'm like, great. How well are you doing it? How often are you doing it? And that's when I'm usually met with, oh, I'm not. So we really have to reflect on like, well, we know a lot of things and there's information everywhere. Are we making conscious decisions? Because they are that powerful. Even if your provider says to you, like, diet doesn't do anything. It really does.
Yeah. All right. So we had a little technical difficulty. Sorry for all those listening. So we're just going to wrap this all up because Dr. Jolene has provided so much value. And I really want you to go dig into all the goodness she shares on her website, her blogs, through her socials, because there's just so much wealth of information and we could only touch on so much in this episode. So of course I will include all her information in the show notes, but if you could just tell people where to follow you, what would be the best place?
Yeah, well, there's a ton of information that's at drbrighten.com. And if you are someone who is struggling with your libido and your hormones, know that we've got something special for you. If you go to ITN book, so Dr. Brighten /ITN book.com, you can check that out. For everybody who grabs a copy of Is This Normal? We have got some really awesome bonuses and goodies there for you to say thank you. And then, of course, you can find me on Instagram and TikTok at Dr. Jolene Brighten. And if you want to follow along more of my personal journey in life with my own fertility, you can find me on YouTube sharing all of that.
Amazing. Thank you for providing that, just for people to go look further into you and then also your upcoming book that will probably be available for pre-order by the time this releases. So that is amazing. So I just want to close off in asking the question I ask everybody, because I feel like everybody leaves such a brilliant piece of advice that all of us could take into our life and really apply it in some way, shape, or form. So question is, if you were to leave a piece of wisdom, a life lesson you have learned in your journey that you feel just anybody needs to hear right now, it doesn't necessarily need to be on your topic, but just a life lesson that you feel anybody needs to hear, what would that piece of wisdom be?
I would say not everything is about you or has anything to do with you, which is important, I think, in your journey in terms of releasing stress. Because as women, so often, if we have an interaction with somebody and it feels like something's off, or somebody leaves a gruff comment online, or you interact with your doctor and you're like, are they having a bad day or is it me? We tend to fixate on that, replay it, maybe go to bed thinking about it, and it can cause stress. And I think it's one of the easiest things that you can let go, where you can just check in, like, is this really about me, or maybe is this their stuff?
Amazing. Perfect. Yeah, I think that we so fixate and we go into like a negative spiral when we're focusing just on, oh, it's all about me. They're focusing on me. I'm taking this personally because it's all about me. So absolutely. Well, this has been such an honor. I'm so sorry for the technical difficulties, and just appreciate. This is the virtual world we live in. That's the difference with being in person. At least you don't encounter too many things, except we were recording in the room. And I remember like there was a big, like the event ended and there was a big uproar. So it's like, well, that happens too.
Yeah, there's that as well.
Yeah. Well, it's been such an honor connecting with you. You're such a beautiful spirit. And I just, obviously, you have so much knowledge in this space. And, I think for anybody that wants to learn more, women out there that want to learn more about your health and really how to optimize it, Dr. Jolene Brighten's your person. So
Well,
thank you
thank you
so
so
much.
much.
Thank you so
Yeah,
much for
thank
your
you.
time. It's been a blessing. Appreciate you.